So it is now my pleasure to introduce our keynote speaker, Dr. Eric Holmboe. Dr. Holmboe is Chief Research, Milestone Development, and Evaluation Officer of the Accreditation Council for Graduate Medical Education, ACGME. He's also Adjunct Professor of Medicine at Yale University, the Uniformed Services University of Health Sciences, and Northwestern University Feinberg School of Medicine. He served as Associate Program Director, Yale Primary Care Internal Medicine Residency Program, and the Director of Student Clinical Assessment at Yale University School of Medicine. Before joining Yale in 2000, he served as Division Chief of the General Internal Medicine at the National Naval Medical Center. He also previously served as a Medical Student Clerkship Director and Residency Training Officer at the Portsmouth Naval Medical Center. Dr. Holmboe retired from the U.S. Naval Reserves in 2005. He's a graduate of Franklin and Marshall College and the University of Rochester School of Medicine. He completed residency and chief residency at Yale New Haven Hospital and was a Robert Wood Johnson Clinical Scholar at Yale University. His research includes interventions to improve quality of care and methods in the evaluation of clinical competence. Importantly, Dr. Holmboe is lead author of a recent publication in academic medicine titled, "Will Any Road Get You There? Examining Warranted and Unwarranted Variation in Medical Education." With that, I will turn it over to Dr. Holmboe. Thank you.
Thanks, Greg, for the kind introduction. I'll just wait until.
Yeah, let me, here we go.
No worries. Awesome. Well, hello, everybody. Thanks so much for having me. I'm really excited to be with you, and I hope this is helpful. My task today is to give you a little bit of a higher overview of kind of what's going on in the kind of health professions world around improving outcomes, and particularly just how important the educational process is. Obviously, there's lots of things that impact outcomes for our patients, but I can tell you, and I'm sure you all know this, that policymakers are looking to us within the health professions world to improve our educational practices as part of the solution to improve the care we provide. And so I'm going to cover three things in the next 30 minutes, and I'd love to have a robust conversation after that. First, I'm going to discuss the link between outcomes-based education and improving care for patients, families, and communities. Second, we'll talk about the role of educational program design in achieving desired outcomes, which is obviously a major theme of your retreat this week or symposium. And I'm just really excited that you're taking on this challenge of warranted versus unwarranted variation. And then finally, I'm going to discuss the importance of what's called the core components framework and programmatic assessment tied to curriculum in supporting professional development. Before I begin the kind of content part of the talk, I do want to start with a thank you. It's been a really difficult 3 years. Everybody's been impacted by the pandemic. And we've seen these kind of shifting societal response to it. On the left is a very profound mural that was created by a Mexican artist, where she created a picture of a nurse using the photographs of 198 healthcare workers who had died from COVID in the early parts of the pandemic. As you know all too well, later on in the pandemic, as misinformation became a real challenge, many of our health professional colleagues came under a fair amount of duress, including hostility, threat, increased bias, just outright racism because of the kind of concerns around these various treatments, and unfortunately driven by the misinformation. So it's been interesting to see the shift, and thankfully things are getting much better. But today, by the way, was the first day where we dropped below an average of 200 deaths a day for the first time in the pandemic, which just shows you how profoundly we've been affected by this virus. So let me kind of jump off from the pandemic and just make note that the pandemic also surfaced a lot of challenges in our healthcare system that we already knew existed, but were further exacerbated. This is a really interesting report from the Commonwealth Fund in New York. They do something called Mirror Mirror, where they compare our performance against other like democracies in the Western world. And you can see that our overall ranking is dead last out of these 11 countries. We do better than most on care process, good for us, but we do very poorly in access, administrative efficiency, equity, and outcomes, which is pretty depressing, given how much money we actually spend for healthcare. And just to put a finer point on it, this is pre-pandemic, but this looked at the change in what's called avoidable mortality. In other words, it's mortality that's amenable or avoidable if you get the right healthcare. And this is the change between 2009 and 2019. And you can see for all the other countries, all of them made substantial improvements. The majority made improvements of 15% or more in reducing mortality. Only Germany was at 13%. But you look at us over that 10-year period pre-pandemic, we only improved by 5%. In other words, you're only able to reduce avoided mortality by 5% during that 10-year period. And so again, it just shows you how much work we have to do as an education system to at least contribute to try to address some of these big challenges. And so at the end of the day, since this is a talk about outcomes, the ultimate goal is really to achieve what many folks now refer to as the quintuple aim. This is itself undergone evolution. It started as the triple aim. It's now the quintuple aim, where we want to improve population health. We now call out explicitly health equity, pulling it out of the original 6 aims of quality from the Institute of Medicine's report in 2001. We now understand the importance of clinician well-being, and boy, has that been affected by the pandemic. We see, for example, a particular problem in the nursing shortage, huge issue. We also want to enhance the care experience of the patient, making sure the patient receives care that is safe, equitable, efficient, effective, timely, and patient-centered. And then finally, we really do need to continue to try to strive toward reducing cost, because again, that's a big problem in the United States. And so if that's the North Star, the quintuple aim, how do we get there? Well, you have a major focus at this get-together on curriculum, which is really important. And obviously, you need to have an integrated curriculum with assessment. You've all heard the adage assessment drives learning. That is true. But I would argue too often we don't pay enough attention to the other side of that loop. Curriculum, when designed well, should drive the right type of assessment, and they need to feed off each other as an ongoing loop. We use competencies or abilities to define what we want our professionals to be able to do at the end of a training program. And then we have to have a mechanism on how we express those outcomes as educational outcomes of the learner. And now we're using things like milestones of the competencies and entrustable professional activities. It's also critical to note that this has to occur within a high-functioning clinical learning environment. That's the CLE. As I'll show you in a little bit, the performance of the institution where the training is occurring will have an impact on what the learner themselves are able to do when they enter clinical practice. So if we're talking about outcomes-based education, let's just start and go back with definition. This is not a new concept, as you might imagine. However, this is a nice article from one of the leaders, Ron Harden, at the University of Dundee, who just recently retired. Ron's amazing. He's in his 80s and still active. But in an outcomes-based approach, logically, you start with the end in mind, which means we need to focus on what type of health professional will be produced and the structure and process flow from the outcomes. That includes the structure and process of the curriculum. And as Ron and others have pointed out, those educational outcomes have to be clearly and unambiguously specified, because they will determine your curriculum, assessment processes, and the learning environment needed to achieve those outcomes. The other way to think about outcomes is to use what's called a logic model. This is a really nice a diagram from Elaine Van Mel at Queen's University, who's a PhD educator. And so the logic model, though it's depicted in a linear fashion, we know that's not how educational programs work. They work as kind of ongoing loops, as I just showed you, but it helps us to think about what is we really need to achieve the outcomes of interest. And you'll notice on the input side, we have to have the right curriculum tools and resources and design to achieve the outcomes we're really looking to seek. On the output side, we need a curriculum map that links the teaching, learning, and assessment together. And from an outcomes perspective, the first proximal outcome we're interested in that we know is tied to what happened in the program is the educational outcome of the learner, right? So that's things that we really need. So for example, learners who can demonstrate several learning, who have the abilities they need, and also that within the training program, we can make sure that we've identified residents or learners who require remediation and they're ready for practice, okay? Now, the activities are also really important, and I'm going to come back to that in a minute, using the 5 core components as the way to think about that. The other reason why this is so important is that we know that educational activities, when done well, do link to outcomes. This is a really nice article now over 10 years ago, but from Wendy Levinson, who's a real leader in communication science. And they have shown through their work in this review that you can go all the way back that if you teach patient-centered communication skills, then you can measure these outcomes, and that those health professionals, and this is true for all health professionals who possess, better, more mastery level patient-centered communication skills, can achieve these kind of outcomes, including, by the way, improved survival, reduced cost, improved quality of life and well-being, something that's so central to what you do as physical therapists. And so it's not that these are nice to have skills, they matter, and they link from how we educate to what patients actually experience farther down the line. So in order to achieve the outcomes we desire, we have to figure out a way to operationalize outcomes. That's where competency-based medical education comes into play. And this is a definition from an international group of educators who got together over 10 years ago, led by the Royal College in Canada. But they define CBME as an approach to preparing health professionals for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from analysis of societal and patient needs. Again, taking us back up to that quintuple aim. It de-emphasizes time-based training and promises greater accountability, flexibility, and learner-centeredness. Now, one of the big criticisms of CBME that we hear, and I wonder if you hear the same in physical therapy, is like, okay, so what you're saying is CBME is all about shortening training. That's not the case. In an outcomes-based model, time is viewed as a resource and one that should be used wisely and seen as precious and not as the intervention or measure. As Greg was talking about curricular bloat and keep adding things on, the way we typically add things on is either through content, and sometimes we add on time. Now, adding time may be perfectly appropriate depending on where the field is, but that should be a really thought out decision about how that time is going to be used, because too often, I can tell you in medical education, time is used as a proxy for competence. For example, I'm a general internist by training. During my residency, it was required by my certification board to do at least 3 months in the intensive care unit. With the theory being if I took care of really sick people in an ICU setting, I'd be able to recognize them in an outpatient setting. That's the theory, but that was never measured to see if that actually occurred. The only thing was measured is whether I did the 3 months in the ICU. And so for us in the GME system, we're really trying to get folks to think about time as a resource and understand that we still have to deal with fixed time because of financing all kinds of those issues. But we can build an outcomes-based flexibility within our residencies and fellowships, depending on where the learner is developmentally. And that brings us to the core components framework. Again, this is also work led by Lane Van Mel. I find this very helpful. This is what we use, for example, to frame our week-long assessment course. And there's 5 core components. The first is outcome competencies. In other words, you need a framework and competencies that are required for practice, and they have to be clearly articulated. The second is this concept of sequence progression. In other words, competencies and their developmental markers are sequenced progressively. This obviously has significant implications for curriculum. Again, I apologize, but I'm going to share an example for medicine. Too often, we just schedule folks in medicine based on service that we need to fill. From a developmental perspective, however, one might question whether or not taking a new graduate right out of medical school and putting them in as their first rotation into an intensive care unit really makes sense from a developmental curricular perspective. Are they really ready to get the most out of that experience at that time? And I would argue probably many aren't. And so that's a real challenge we have. And then that brings us to the other three components, which are tailored learning experiences, competency-focused instruction, and programmatic assessment using system thinking, where learning experiences facilitate, teaching practices promote, in other words, curriculum, and assessment practices support and document the developmental acquisition of the competencies. You'll notice that in 4 of the 5 components, the word developmental. That's deliberate, because becoming a health professional, whether you be a physician, physical therapist, nurse, is an intensely developmental process, as we'll see in a moment. The other thing I really like about the core components framework, I encourage you to think about this through the lens of your curricular redesign and reform, is that it's grounded in a growth mindset. First, it forms the basis for significantly redesigning assessment practices, instructional methods, and learning experiences. The diagram up here on the right is the typical block design for a curriculum for medical school and then a residency. And the question is this really the best design to support development? I literally raised that as a question. Is that going to really support the learner on their trajectory? The second important piece is that the CCF, the Core Components Framework, is focused on promoting learner growth and development through frequent formative assessment. In other words, assessment for learning is part of their curricular experience. And so off to the right, this is the famous Kolb cycle from David Kolb's work. And although I probably can't read the text, what you see in green here are the assessment actions, and all of that in blue is the teaching and curricular actions. They're both important. Finally, the Core Components Framework emphasizes that the training must be rich in feedback and coaching that is individualized to the learner and grounded in the desired competencies. And finally, provides rich and diverse learning experiences steeped in clinical practice where learners can stay as long as required. The diagram on the right is the work of Joan Sargent from Dalhousie. This is known as the R2C2 model of feedback, which has been shown to really emphasize the importance of coaching and using the experience of co-production with the learner to build learning plans, to figure out where they are developmentally, and so that they can really advance in a way that makes the most sense for them. So let's talk a little bit more about those 3 middle components: progressive sequencing and the tailoring of learning and teaching. One thing I just want to point out about the Core Components Framework, and is also as you're thinking about curricular redesign, is that it is deeply theory and evidence informed. As you can see here, there are all kinds of educational theories in play. And when we work to educate our health professionals, no single theory is going to do the job. It's an amalgam of all these different pieces of science from the educational literature that we bring together to help achieve the goals that we're seeking. And I'm going to cover just a few of these as kind of exemplars. So one that we use in graduate medical education is the concept of a stage model development. The one that you may be most familiar with is from the Dreyfus brothers, and they kind of describe these 5 stages. Now, these stages are not meant to be kind of a stepwise linear process, but rather to describe or provide descriptions of what somebody looks like. In other words, what they're able to do at this stage is part of designing their own professional development. Another really important body of work is something called deliberate practice. This is from the late, really wonderful Anders Ericsson, who we sadly lost unexpectedly in 2020. Strongly recommend this book, Peak, if you haven't read it. But Anders pointed out that you need deliberate practice to help people achieve expertise and mastery. And he defined it as individualized training activities, especially designed by a coach or teacher to improve specific aspects of an individual's performance through repetition and successive refinement. You may see a kind of a building theme here, that when you think about curriculum, curriculum should also be attached with coaching. Coaching and feedback is a critical part of the curricular process. And as Andrews points out, it requires fields that are reasonably well developed, where you have clear mental representation of the task of that discipline or profession, that are well defined, and that they're shared. There are shared mental models among those who are doing the teaching. And as Greg pointed out, I would argue what we're seeing across multiple fields is this lack of shared clear mental representation is one of the contributors, by the way, to the unwarranted variation problem that I can tell you all health profession educational programs are experiencing. And then the final concept I will share with you today is the concept of mastery-based learning. This is wonderful work by Bill McGahey, who actually wrote a paper on competency-based education for the World Health Organization for, wait for it, 1978, where they argued that we needed to use a mastery mindset in training health professionals. Because a mastery mindset basically means that excellence is expected and achievable by all learners who are able, motivated, and work hard. There is little to no variation in measured outcomes. Learning in any domain depends on learning a sequence of less complex components. And if learners receive optimal quality of instruction and learning time required, curriculum, the majority of learners should attain mastery. I think this is a wonderful mindset. We're not training folks to the floor. The goal is to maximize their potential and ability during the time they're with us as part of their formal training. Why is this so important? Well, this is what learning curves actually look like. If you haven't read this wonderful work from Martin Pusick, strongly recommend it. This is a nice article from 2014, kind of laying out the issue. And as he points out, learning curves are sigmoidal. They are not nice 45-degree stepwise inclines. And the reality is that when they're with us in the health professions education programs, they're on the steep part of the curve. And our goal in our using our stage model development is to get them to proficiency, where in the entrustment language, that means they're now ready to practice without supervision. That's our goal. However, you'll notice they're not done. If they truly want to reach toward mastery, they have to engage in continued deliberate practice to become a deliberate expert in their particular craft once they leave us, which means they need skills like self-regulated learning, reflective practice, and so forth. And the competencies, again, just simply provide a framework to guide that journey about what are the abilities you need to be really a high-functioning physical therapist, right? Someone who's truly an expert in the care that they provide. And so for us, as we think about curriculum, we also have to think about assessment, as I said. And so that fifth kind of component is programmatic assessment. And this is how we look at it within the GME world. I work on the right-hand side of this diagram. I'm in the accreditation oval. There are certification and credentialing processes where the unit of analysis is the individual, but we are joined at the hip, so to speak. There are a lot of interdependencies between these two parts of the self-regulatory system. And together, our primary constituency is the public. But here's the bottom line for those of us who work in regulation. We're only as good as what happens inside that rectangle. So we've been talking about kind of important curricular concepts through the core components, but this is kind of the key aspects of a good assessment system. The right type of assessments that cover all the competencies in the gray box, that generates data that is accurate, reliable, and valid, that comes to a committee that uses that data to create a synthesis and determine where somebody is on their developmental trajectory. And we express that developmental trajectory on the milestones using the stage model as a way to represent it. And then when the system works well, that information is fed back to the residents, but also back to the faculty, where the faculty and the program director use it to improve the program, including changing curriculum where there might be gaps recognized if multiple residents are having a struggle, and by the resident to write an individualized learning plan to think about what their curricular activity should be over the next 6 months. You'll notice in this model, The resident is an active agent in the assessment system. They have to contribute not only to their learning, but also to their assessment. Again, we're using this mindset of co-production. So let me just kind of share with you quickly what we are seeing, in other words, what our graduate medical education system is producing. And what I'm going to show you are examples of the kind of variation you don't want to see. So this is an example of what we've learned about looking at trajectories using our national milestone data. This is obviously much more crude than what I showed you for Martin Pusick, because we get data points at every 6 months. But you'll notice that in this particular competency, at the time of graduation in 2016, this was our very, first work in this area, 20% of the graduates did not attain proficiency as judged by their program at the time of graduation for this competency. And so that's concerning, right? Is this kind of variability that we really want? And the question then becomes, can we identify them earlier? And that's work we're doing to create a national data system to help programs use it as feedback so they can redesign learning plans for the learner to help them fill gaps and deficiencies. This is our recent data from my field, internal medicine. We provide this every year. This is a box plot showing what the final ratings were for residents who theoretically were graduating. And you'll notice that level 4, again, is the goal. And the good news for both practice-based learning and professionalism, remember, this is ethical principles here, the majority were judged to have done fine. But you'll notice the whisker here and the outliers in the circles. And is that really what you want to see at the end of training? So we do see a distribution, including folks that were judged by their programs not to have reached proficiency, and some with very concerning deficits as judged by their program, theoretically being graduated to move into unsupervised practice. And the question for us is, are they really ready for that? Particularly around ethical principles, for example, or their inability to use evidence-based and informed practice. This was just released this past Tuesday. This is comparing milestone ratings in professional and interpersonal communication skills using an interesting registry that's been maintained by Vanderbilt over the last 15 years that basically captures various types of patient complaints from a large number of hospitals that are contributing and participating in the registry. And essentially, the reference here is a milestone of 4, which again equals proficiency, as I just mentioned. And you'll notice that for those who get lower ratings, they're more likely to get a major complaint from a patient in their first year of practice. Those, interestingly, who got higher ratings, even though it crosses 1, so it's not statistically significant, appear to do even a little better or less likely. But the point here is that these folks are going out into unsupervised practice, and they are getting these complaints that have been shown to correlate, by the way, with state medical board actions, but also with complications among surgical physicians. And so, again, we see this type of variability, and that's concerning. And so I love this quote that's often attributed to Deming, but it's also been kind of modified by Paul Batalden and Don Berwick. And it goes, every system is perfectly designed to get the results it gets. So within graduate medical education, we have multiple ongoing examples of fixed time GME system that's persistently producing variable outcomes. And the question is that really what we want? Part of this is going to be due to deficient assessment practices, but I would argue part of it's also due to variability in curricular activities. We know this to be a problem, that there isn't a sufficient attention in the curriculum to embedding, for example, quality improvement and patient safety is one example we're struggling with within medicine. And so I just want to end with a couple of things and then we'll open it up. So given all this kind of data that we have and what we're seeing, how do we study complex interventions and phenomena to ultimately improve the current status or current situation? And so you're doing some great work in physical therapy. This is a really nice article from Gail. Again, thank you to Gail and Greg for sharing this for me. But you'll notice that you need a framework. And what's really important is you'll notice is that there are really important activities that are nested within each other. And so if the goal is to meet societal needs, putting that at the center, which is what I love about this diagram, you have to think about learners, their progression, and their outcomes-based assessment, and how the curriculum supports this. And then you're going to have to train faculty, right, in order to be able to do the right kind of assessments. But think again about the core components framework, where you have to tailor the learning that's needed by that particular learner, depending on where they are. And then, as I've talked about, the learning environment matters. And then ultimately, you need an education research framework to help guide this very important work that you're all engaged in. And so this is something that we've been working, is that we think about our work. We always put the patient or society at the center, recognizing that educational and healthcare outcomes actually overlap quite a bit. We should not see these as separate. You know, the patient and family sit at the center. We have all these interactions and interdependency between the learner, faculty, the healthcare team, and the training program that really maximize the probability for both good educational outcomes and healthcare outcomes. These are all embedded in what are called clinical microsystems. These are typically where the care is being provided, such as a physical therapy center or clinic would be a clinical microsystem that might be embedded within an institution, such as a hospital. If somebody's just been hospitalized or has recently had a joint replacement. And certainly the societal community needs an influence buffet this process all the time. And that's something we always have to account for. Why is this so important? Because, well, as I was kind of alluding to several times, the environment also has a major impact on what happens to our learners. Again, these are all medical studies, but they've all shown that the quality of care being delivered at the institutional level is directly associated with the care the graduates from that institution provide once they finish training. With David Ash in 2009 found a direct correlation between where an obstetrician trained and what their future rate of major obstetrical complications were in practice. Candace Chen and Bob Phillips looked at cost of care in internal medicine, family medicine practice, and again found that if you trained in a high-cost environment, guess what? You were a high-cost provider. These three studies also had a pretty sobering finding as well, is that that effect or imprint, if you will, lasted 15 years. So, as I like to say, I call this the reverse Vegas rule. So what happens in your institution is not going to stay there. And in some respects, if you think about that, well, actually, that's a good thing. So if we can really maximize our training program from curriculum and assessment, they'll take that with them. And that's exactly what we want to have happen. And so one of the other lenses we use is something called the realist framework from Ray Paulson and Nick Tilley, who've worked in this field for years. Nick is now retired, but they've been really helpful in guiding us to how to think about this. And so when they're thinking about outcomes and designing programs, and they used to do a lot of, believe it or not, kind of community-based programs for crime prevention is where they got started, believe it or not. And now they, Ray particularly has moved into healthcare. But they ask the question, what works or doesn't, for whom, in what circumstances, and why? So as you know, we have these milestones I just showed you. And so the action is implementing the milestones. But it's only going to be causal if its outcome, which is better care and a better prepared physician, is triggered by a mechanism acting in context. Well, what are the mechanisms? Well, for us, it's choosing the right assessments. It's the faculty development. It's making sure the clinical competency committee is able to do its work effectively. And then this all occurs in a context that affects whether or not somebody is truly ready for unsupervised practice. And as I just showed you, the hospital culture and performance will impact how well they do when they enter unsupervised practice. And so this is also important because we need to connect the continuum. And so again, this is an example starting with undergraduate medical education, UME, to GME, the world I work in, to actual practice, which we call continuing certification or continuous professional development. And so one of the things we're trying to think about, how can we create warm handoffs between different aspects of the system? So as you move from medical school into residency, could we provide information to the receiving residency program to help that learner really get off the ground quickly? And then how do we feed that information into practice? And then how do we feed information back from practice into GME into medical school to help those programs get better, to redesign assessments, redesign curriculum, et cetera. And then into practice, maybe we start to use clinical performance data. Understanding, again, this is a sigmoidal learning curve, and we're trying to drive folks to becoming a deliberate expert. And so moving forward, I'm just going to share a few things. I love the fact that this was introduced as disruptive innovators. Perfect. And so you'll probably recognize a few of these things. Here's things that we're experiencing as challenges in implementing competency-based training. Honestly, one's just inertia. I talked to Bill McGahey. I interviewed him recently, and I said, Bill, what do you think medical education's biggest problem is? And he said, oh, that's easy, inertia. That was the very first thing that came right out of his mouth. The second is change management, and it's hard. We have to remember that change is more often about a loss of identity than change itself. You have very dedicated educators in the physical therapy space that have been working at this for a long time. When you come to tell them that, hey, we think we need to be doing things differently, they may not see that as an opportunity, but a threat or a sense of loss. Like, wait a minute, I've been working at this for 20, 30 years. You're not telling me what I'm doing isn't good enough? That's what they may hear, even though that's not what you intend in any way, shape, or form. And then we need competence to do this. We have to have implementation knowledge and skills, and we're going to have to change rigid curricula. This is particularly a problem for us in medicine. I also love on this quote, kind of getting at that change is lost. This is from Heifetz and Linsky, an interesting book. People do not resist change per se. People resist loss. You appear dangerous to people who question their values, beliefs, or values of a lifetime. You place yourself on the line when you tell people what they need to hear rather than what they want to hear. Although you may see with clarity and passion a promising future of promise and gain, people will see with equal passion the losses you're asking for them to sustain. And so one of the things I think is a big challenge, I think will be something I suspect will come up over the next 2 days, is that we have to deal with what's called the big assumption. This is from Elizabeth Leahy and Robert Keegan at Harvard. And they talk about how many things become that our assumptions become our truths. And they say that big assumptions are not so much the assumptions we have as they are the assumption that have us. Let me give an example of an assumption in medical education. It's that rotational model I showed you earlier. We assume you have to use rotations and you have to have X number of experiences in order to be ready as a general internist. That's an assumption. It might be true, but we should treat it for what it is, an assumption. And so in our case, we're asking them what assumptions exist in a graduate medical education community that we hold tight that might be holding us back. I have the same question for all of you. Are there assumptions in the physical therapy world that might also have a similar impact? And then finally, I just want to end with something called Theory U. This is from Otto Scharmer. I kind of love this model. And essentially, the U is the journey. And so he talks about first levels of listening. And so what we tend to do, we're at the top, is that we listen from habits. We download habits of judgment, and we reconfirm them in opinions and judgments because they work for us. And then the first step when you're working with folks is get them to at least listen from, quote, the outside. Listen for kind of facts, get them to notice differences so they have an open mind and maybe they're willing to hear disconfirming data. Then the next step is really emotional. It's empathetic listening, listening from within with an open heart so that you can see through another person's eyes and make an emotional connection about what they might be struggling with. And then finally, listening level 4 is from the source, what's that he calls generative listening. It's really about the future you want to emerge. And so it's connecting to an emerging future whole. It's a shift in our identity and self. So the left-hand side of that U is letting go, and the right-hand side is letting something better emerge. And so with that, I thank you very much for the opportunity to talk with you. I hope this has been helpful. I certainly welcome your feedback, and I am going to come off screen share.
Wow, thank you, Dr. Holmboe. Excellent presentation. Really made me think about a lot of assumptions, I think, that I have as well. So let me go ahead and open up the floor for questions for Dr. Holmboe. We've got him for about the next half hour-ish for Q&As related to his presentation. So if you have a question for him, just raise your hand.
Or feel free to type anything in the chat, including reflections or feedback. I'd really appreciate it.
Perfect. Yeah.
Yeah.
All right, Elsa.
I'm intimidated to go first, but here I am. Thank you.
Go for it.
It's just been so thought-provoking. So thank you so much for this presentation. I think that it is incredibly valuable, and I think that we are probably all struggling with these concepts immensely in our programs. I think that the pandemic brought all of these concepts to the forefront, and we are seeing this so much in our learners, and in our most recent classes, it has become so obvious that we need to reinvent ourselves. So this concept about allowing the students, however, the time that they need to accomplish the competency level is a very commendable concept. But when it comes to, and I'm just being a devil's advocate here too.
It's totally fine.
When it comes to the idea of the reality of cost, the reality of student debt, the reality of resources, and what I am seeing in our particular program is that the faculty has absolutely had to turn towards this direction of the formative feedback, the length of time, the catching it early, the providing the resources, the assistance of this. But this is also leading to exhaustion.
Yep,
and,
exactly.
And at what point, without sounding ugly, enough is enough, and at what point you do need to realize that maybe a learner is not going to be able to continue to move forward as much as you provide these resources. And at what point, unfortunately, sometimes they do get moved forward because of that exhaustion.
Yep.
So anyways, lots of thoughts.
Yeah, so there's a lot in there, Elsa, and it's all really important. So you bring up a couple really good points. First off, when you have a learner that's struggling and needs more formal remediation, that is a very labor-intensive process. I can tell you in medicine, some of this work has been done by Karen Warburton, who's done wonderful work at University of Virginia. And she has basically calculated how much time it takes to really intervene to help somebody get back on track. And it's 45 hours on average. And so that's the reality. And so, part of it, at least in the kind of our medical education system, is folks are getting passed on from medical school when they really weren't ready. And so that, you would hope that they could address some of that moving forward. But sometimes you're right, you do have to make the tough decision to let folks go. And that's not easy. There are some really good books. If you, I'm happy to provide a reference, about how to approach this systematically, and then how do you make that tough decision when somebody may need, it just really should move forward. And I get the whole cost thing. Like I said, I'm a former training officer, program director in the Navy as an associate PD at Yale. I've run clinical assessment, and it's very challenging. I do think we have to, think of the flip side of that. What's the cost of not doing it? Because we know if those folks get out into practice, they're higher risk and they can cause harm. And so we've seen some very egregious example of that over the years. The Michael Swango affair, more recently, Christopher Dunch in Texas, the neurosurgeon, who a lot of patients died. And he should have never have even gotten out of medical school, let alone residency. And so I think there's the other side of that, is that if somebody really isn't ready, what's the societal cost moving forward? And I think we have to do a better job of advocating, like we're trying to do right now with Medicare. It's like, right now institutions pick up the cost, fine, but do you really want that person out in practice? You've just invested all this money. Could you give them 3 more months? And I think the pandemic has really brought that to fore. So fantastic observations, Elsa. This is a complex issue that doesn't have a single answer. Yeah, Angela, I think you're next. Angela, sorry.
Yes.
Thank you. No, Angela. So pardon me, my husband is a surgeon actually here in Connecticut. And I know I've heard him say a few times, there's an old adage that a monkey could be trained to do an appendectomy, meaning that much of the higher level skill of surgery is not just the technical skills, but for what patient to do, whom to, who's the best candidate for these procedures, and to
Oh
get
yeah, that. You mean clinical reasoning?
clinical reasoning.
Yeah.
So
Huh.
that being said, you know, as we're going through that, you were talking about time and repetition and all these kind of things. I mean, you know, and especially how some of the non-technical skills can be hard to replicate depending on the scenario. How do you balance these technical skills with some of the non-technical skills, such as the communication and the professionalism and the ethics that you mentioned?
Yeah, it's a great point. So just by the way, where are you in Connecticut?
I teach actually up in Springfield College in Massachusetts. He's at Connecticut Children's.
Oh, awesome. Well, tell him, thank him for his service. I used to go up to the sim lab at UConn. So yeah, I think there's a couple elements there. So and again, I apologize, Angie, I'm going to use a kind of our medical lens here, given this experience we've had. I think from the standpoint of technical skills, we know from wonderful work, for example, done by Brian George at University of Michigan, that if you sample enough across enough cases over time, you can make good entrustment decisions. And so the challenge is really sampling sufficiently across multiple procedures, you know, of different types of patients. The other piece is that we have to train faculty to do assessment better. That has also been a problem. And Greg, thank you for highlighting the article. And that's one of the arguments we make in that article. That's not going to solve all problems. It'll make things better. The same thing holds for communication skills. It turns out that communication skills, professionalism are much more impacted by context, right? You know, the kind of patient, because the patient's interacting and there's unlike being asleep for a procedure. And so again, same principles hold, but I think there's where we don't see quite the same application of the evidence we have, for example, around communication skills. Now, we just finished a randomized controlled trial we published this past year. Like, you can get faculty not only be better assessing those skills, but guess what? In the process of doing that, they themselves are picking up additional communication skills. One of the big challenges, Angie, we're also having there, I hate to say it, and we're seeing this in medicine, I don't know if this is true in physical therapy, but a lot of our faculty are being asked to assess skills they themselves were not sufficiently trained in, and they know it. And they're honest about it. And so I'll be honest, like quality and safety, no training when I was a resident. And I love my residency, don't get me wrong. Interprofessional teamwork, that term didn't even exist when I was training. So we have to recognize some of our faculty are going to have to upskill as well. And so we may need to use in certain settings kind of co-learning with various groups, or make sure that it's not just about improving their teaching or assessment skills, but help them to upskill in areas they may not have been as well trained in as well. So I hope that was helpful.
Very much. Thank you.
Yeah. Is it Miles next? Do I have that right?
Yes, you got it right. Thank you. What a thought-provoking discussion for a Friday afternoon, I might add. So
I'm so sorry, right? We should
No,
be
not at
opening up
all.
a glass of Pinot, right? Or something like that.
Exactly. You woke me up. So I have a comment, but I'm also very interested in your insight about this. The variability in education has long been a conversation for many years, many years. So here's my question. One, I don't believe that we can really get away from variability for many reasons. We pride ourselves in being individual in each education that we give to the students. I don't know what your thoughts are about that. And so if we really cannot get away from variability, then maybe the question would be, how much variability is okay? And if that's the question,
That's the question.
how do we measure how much variability is okay in healthcare education, in PT education?
Yeah, well, let's see. Do we have an hour? But that is a fantastic question. Yeah, so I think you've hit the nail on the head. There's always going to be some variability, and some of that is Greg called it. And this actually comes out of work from a gentleman by the name of Jack Wenberg at Dartmouth, who studied this over 50 years. Some of that variation is in fact warranted. And so it really depends on where is that variation acceptable and actually helpful. So I'll give you one example from a patient perspective. You know, if you're helping a patient make a decision about what type of therapy would be best for them, right? And there might be various options. They may choose something different versus another patient. That's perfectly fine. And then it's your expertise that's guiding them to make the best decision for them. On the faculty side, you're going to have faculty that clearly have strengths. And there are areas where they love that particular aspect of education, and they're your experts. And so they're going to appear to be idiosyncratic because they're focusing on things that they're particularly good at. Take advantage of that variability. That's good variability, right? They're actually providing an additional resource to the learner. The problem comes is that when you have faculty that are engaging in less than optimal teaching, clinical care, and other practices, and then when that happens, that becomes problematic, because think of it from a learner's perspective. Let's say a learner works with 3 of us, and 2 of those individuals are actually really good at what they do, and they're focusing on areas that's actually very evidence-based and expert level, but now you have one that isn't. And we're asking the learner to decide which of those that they're going to actually choose, right? They're the ones having sometimes to deal with very discordant feedback. And we're asking the most junior person in the system to make sense of that. And they may not be in the best position to know what is actually best practice, right, or effective practice. And so, Miles, I think that's the tension we feel. I'll try to put it in the chat. And thank you so much. It's great stuff coming through. I'm sorry I can't keep up with all of it, but there's a wonderful article from Marianne Govertz. She's the lead author, and it's this concept of polarity management. And the concept of polarity management comes from Barry Johnson's work, where instead of thinking it as an either or, it's a both and. And how do you maximize the value of standardization, right? Where you really should have it. Like, for example, when you do a thoracentesis, there is a very limited number of ways to do that properly, period, right? On the other hand, it's different depending on what you're dealing with, versus the flexibility, adaptability, and warranted variation that helps a learner and a patient at the same time. And it's that tension between those 2 poles, and you need both.
Thank you.
Of course. Jody.
Eric, how are you doing?
Good. How are you? Good to see you. What a treat.
Oh, we kind of know each other, so I'm going
You
to
may have
give you.
picked up on that. Yeah.
I'm going to give you a sticky question, Eric.
Oh,
And
come on. It's Friday. You just heard it's Friday afternoon.
I'm reflecting both PT but vet medicine as well.
Okay.
So you talked about a shared mental model. Let's talk first about the fact medicine requires residencies and fellowship. PT does not. Medicine started its model, CBME, in residency and retrofitted to entry.
Okay.
PT is actually doing the same, and that's probably a mistake, and I'll tell you why in a minute. But
Okay.
the real piece is to have a shared mental model means that the profession needs to have a shared mental about what are the outcome competencies. That's not an individualistic, programmatic. It's a profession. So that's the first challenge is how do you get a profession to not tinker and everybody wants to put their own stamp on it and actually agree to that? And the second thing is it beneficial to look at other outcome competencies from other professions and where we align, use the same terminology so we see where we align, and where we're unique, actually describe where we're unique. An example is professionalism or communication or collaboration versus movement system for PT, diagnostic and surgery for medicine, and animal and herd health for vet. Could we, in fact, align where we're similar so we actually understand where we can collaborate interprofessionally and where we have overlap, and perhaps where we're actually unique and we have a unique body of knowledge that reflects the specific profession? So there you go.
What a concept. My God, that's so radical, Jody. I couldn't agree more. I think the shared mental model is a huge challenge. What's interesting is that the reality is that in order to really develop that, you need a series of ongoing conversations and back and forth to work that through. We've been able to do some of that through the development of our milestones, not because we just have a committee do it, but we continually interact with the community, by, for example, holding multiple focus groups, doing qualitative work to refine those. To your point, Jody, what we also did in Milestones 2.0 is that we said, you know what, patient and care, medical knowledge, yeah, you know what, that's specialty specific. We got it. You need to kind of think about that. But you know all that other stuff, professionalism, communication skills, practice-based learning, or is it really that different about what we're trying to accomplish across the specialties? And guess what? The answer is no. And so every single specialty this past time, Jody, has the exact same subcompetencies for those 4 general competencies. I think the more that we can try to, I think at this point, it's a socialization process across the health professions around these other competencies are just foundational core to what we all do, I think would be huge. And I just want to share with you real quickly that that little tool you built around the professionalism tool, guess what? We recommend it as part of our assessment course because there's no need to reinvent the wheel. The stuff that you all put in that tool applies to everybody. And so that's a really good example of a tool that you built that it actually has utility across, multiple disciplines. And so we provide it as an example and recommend folks take a look at it for their own training program in medicine. So yeah,
I want to have one correction. I didn't build it. The Interprofessional Professionalism Collaborative.
I know. I understand. Yeah, that's very kind of you. But yeah, but that group has built a really nice tool, and guess what? It works.
Thank you.
It's a nice example of where we could do that kind of work together. Yeah. Thank you. Nice to see you. Yeah, Todd.
Yeah, I'm suffering a little bit going behind Jody because my question is probably pretty similar.
Okay.
But I was hoping maybe you can expand a little bit more on how medicine decided on what the core competencies were. Like, what was the process? Who drove that process? Was it the accrediting body for medical education? Was it certain leaders in the field? Because we're really in the infancy of really determining what are our competencies.
Yeah, so there's an interesting history here. Believe it or not, it goes back now 25 years ago. So when David Leitch became the new CEO at ACGME in 1997, he was given marching orders to get serious about outcomes. And so what they didn't want to have happen around the competencies is have a bunch of physicians sit around and then define them. What they did instead is they went out and held a series of interviews with stakeholders, including health system leaders, patient advocacy groups, and so forth, about what it is they were expecting to see from physicians. That process was partly informed by what happened in Canada. The catalyst for CanMeds, by the way, believe it or not, was a physician strike in Ontario in the late 1980s. And the physicians thought they'd get a lot of kind of public support. The opposite happened. It blew up in their face. And so what they realized is that physicians weren't attending to what was important to patients, and so they weren't real sympathetic. And so they ended up having a whole series of conversations with patients to really talk about what they expected from their physician, and thus the reason you had communicators, one of the CanMeds, and so forth. As we've revised them, Todd, moving forward, we are involving, again, the multi-stakeholders, including public members, getting public comment, reaching out to folks who are who have lived experience as a patient. That's just so critical. Then we have to talk with health system leaders. What are you looking for when somebody finishes? What have we learned from the 6 general competencies? Have they held up? Do they need to be refined, looking at the literature and the research? So it's a multi-pronged process, but I think in the early days, you want to make sure you have all of the key stakeholders involved in the conversation. One last thing I can tell you is that the Milestones 2.0 revision, probably the 2 most important groups in that revision were first the learners, and the others were, guess what, the public members. And you want to guess what they put a lot of emphasis on? It was that other stuff. I hate to say this, I can do this because I'm old. The more senior physicians just wanted to focus on patient care and medical knowledge, right? That was their mental model. But the young learners, the patients, the public members, they got it. Like, no, that communication stuff's really important. No, you know what, this interprofessional stuff's really important. I really depend on working with the other members of the healthcare team to care for my patients. They got it. And so they were the primary drivers of making sure that those not only were retained, but improved. And I encourage you to think about a similar thing here in physical therapy, whatever makes sense for you.
Great, helpful, thank you.
Yeah, Anne.
Hi, thank you so much for your presentation. I'm interested in the concept that you mentioned about the link between patient-centered communication skills and the patient experience.
Yep.
That's what I teach in our program, and I love teaching it.
Awesome.
Are there specific practices or models in medical education that are shown to improve these skills?
Yeah, I'm happy to share this with you. And if you just want to email me, I can send you a couple articles.
Okay.
We've actually come up with a rubric we use when we teach direct observation that's grounded in the literature about behaviors that have been shown to improve patient experience. So the Levinson article is just a nice one. But there's been some nice systematic reviews that literally go back into the 90s, by the way. One of the first was done by Moira Stewart in Canada. But I'm happy to send a couple of those. And Greg, feel free to share my email with everybody in the slides. But I'm happy to send those to you.
Great, thanks so much.
Of course. Mary.
Hi, thank you again for a very provocative presentation and discussion. My question is, I don't want it to sound chicken and eggish, but we know that there's unwarranted variability in practice as well as in our academic centers. And so, you know, where do you start? Or maybe another way to say it is, how do we address both? Because both are a problem in their own right.
Yep.
But then when you combine them, it seems almost insurmountable.
Yeah, I mean, I think that's the big challenge, right? It really can feel overwhelming. And so, you know, if you look at some of the change management literature, for example, you like John Cotter, for example, you know, folks know would recommend you kind of start with low-hanging fruit, you know, have a burning platform and just start small. That's what we recommend to programs. Like, look, you're not going to fix this all overnight. We know that. Part of the reason the milestones were set up to be mostly formative and not high stakes is that we recognize folks are learning. And they go, what's interesting, Nick Yagmore did a study for us, he published 2 years ago. And guess what? Programs go through their own developmental stages. And so the trick is how to get them from, you know, point A to point B to point C and so forth without having to make a big leap. Because as you think about the kind of sequencing, you know, from teaching, you have to sequence things for programs. You can't just turn on a dime. And so the first thing is to recognize where you are, where are the gaps, where are your pain points, try to address those. Because one of the things, as you know, we have to do in health professions education is we're trying to make these transformations, but we still have to fly the plane. And so I don't know if you've ever seen that famous EDS commercial where the folks are building the plane in the sky. It's hilarious, you know, but that's what we're doing. And that's really hard. And so I think also is part of it is just to get your faculty to understand, to give themselves some grace, you know, get started, build on, you know, and also be willing to let go with things that don't work. We have a tendency to want to keep grinding away at something because we're just convinced this is the thing to do. And if we did X, Y, and Z, we'd be fine. And sometimes the answer is, you know what, it didn't work. It's okay. All right. Adjust, you know, recalibrate. This is a developmental journey. But we have definitely seen that. We're now 10 years into the Milestone Project. And so we've definitely seen this, the developmental program within institutions and the programs themselves.
Thank you so much.
Of course.
Thanks, everybody. Eric, there may be time just for one question from the chat. There was one that stood out for me, and I think it might be a good one to end on.
Sure.
Andrea Feifel asked if she's wondering if you were seeing assessment to support CBE being implemented well right now in any field.
Yeah.
How do programs at the beginning of this work get started?
Yeah. So the answer to that question, thankfully, is yes. So a really good example, Andrea, is, or Andrea, I apologize if I got that wrong there, is Eric Worm's work at Cincinnati. But getting back to what we just talked about a moment ago, he didn't get there overnight. He kept building on it. But there are a couple really key principles. One is to really work with the faculty, for example, that have to do assessment, understand what they feel comfortable doing, where their help are, instead of just simply handing them a new tool and says, use this. So that helps them get by, just simple things like that, and kind of meeting with them on rotations. The other thing Eric did that was really helpful is he created a dashboard so that learners had full access to data. They could use it for getting better over time. There's no surprises. And because they had data over time, they've now been able to use that data to create learning analytics. So they have a sense of whether somebody's on track or not. But that took 5 years to get there. But he got started by just making sure he had the right type of assessments. He made them feasible and doable, and that he just kept working with folks to get that information. Third, he got the residents involved. That's the empowerment, co-production, having them as active agents. They're a huge and wonderful resource here. Use them, right? They can help you make things better, and they want to play. But remember, because of the hierarchy within our educational programs, they often feel reticent to speak up. So they're going to need many times an invitation, but most of them are ready. They would love to work with you on this. So I hope that helped.
Thank you very much. Dr. Holmboe, we are grateful for your time and your expertise and sharing that with us today. I know that it's been a pleasure for me, and I'm sure it has been for everybody else who's been in attendance. So I want to thank you again on behalf of PTLI for spending the last hour and a half or so with us. And we wish you well and have a great
Oh, thanks so much. And again, we're all in this together. To Jody's point, if there's anything we can do, I'm sure we'll learn a lot from your experience. And if there's anything, I did put in the one article I talked about in the chat, that's open access, so there's no firewall. Please let me know, and have a great meeting together. Thank you.
Great. Thank you.
Bye-bye.